Excellent. So we're discussing evidence-based transfusion practice and patient blood management programs. And this is where I practice. I'm an anesthesiologist. This is the original Johns Hopkins building, which still stands right next to our brand new building, which opened 3 years ago. And so half the money came from the president of United Arab Emirates to build this building. The other half from Michael Bloomberg. So the Arab and Jewish philanthropists came together to give us a new hospital, and they hyphenated their names. So with that, we'll get started. And first, my disclosures. So I have been a consultant for 3 different companies involved with blood management. And there is a potential bias in my lecture because I personally had a life-saving transfusion in 1988. So this is me in 1988. I was a third-year resident in anesthesiology at Johns Hopkins, and it was a bicycle versus car accident. I was on the bike, helicoptered to shock trauma for an emergency splenectomy. So they gave me 6 units of blood, and I left the hospital with a hemoglobin of 7. So I was lucky that they didn't over-transfuse me because the blood wasn't exactly safe in 1988. And I might not be standing here if I had hepatitis C or HIV. So I'm lucky they didn't give me more than I needed. So that being said, now we can talk about overuse. It was 3 years ago exactly when the Joint Commission held its summit on overuse in American medicine. And not only did they determine that blood transfusion was the most common procedure performed in U.S. hospitals, but also one of the top 5 most overused procedures. So it was right up there with heart vessel stents, tympanostomy tubes, even antibiotics for the common cold. And this was not just their opinion, this is based on evidence, which I'll show you in a minute. So Choosing Wisely came along in 2013, which is a national campaign designed to reduce unnecessary tests and procedures. And so now we have 5 different societies with Choosing Wisely aims to reduce unnecessary transfusions, including my own society, the anesthesiologist, critical care medicine doctors, the hospitalist, the hematologist, and even the blood bankers have Choosing Wisely aims to reduce unnecessary transfusions. So blood management is so hot that in April this year, the #1 journal by impact factor in the world, which is Nature, did an article on blood management. It was a news article rather than a study. And they recognized in Nature that transfusion is one of the most overused procedures, and we have the potential to save billions of dollars in cost, and researchers are working on how to cut back. So that being said, one of the most attractive things about blood management is it's really one of the few areas in medicine where we can achieve all 3 of these at the same time. So we can reduce risk, we can improve outcomes, and save cost all at the same time. And so we're going to talk about risk, we'll talk about cost, and then we'll talk about outcomes. So we'll start with risk. So I like to divide the risk of transfusion into 3 categories: the rare events, the not so rare events, and then the common events with transfusion. So now in the rare category are things like HIV and hepatitis C. So thought to be about 1 in 2 million transfusions. That means 8 people this year should get HIV and 8 people should get hepatitis C in the United States from a transfusion. But hepatitis B is more common because of the testing window period. So about 80 people should get hepatitis B this year from transfusion. But what people forget about are the more common events like TRALI, transfusion-related acute lung injury, and TACO, transfusion-associated circulatory overload, which are the number 1 and 2 most common causes of death with transfusion. So these are much more common than viral infections now. Also common, or not so rare, are hemolytic transfusion reactions. So most often that's because of the wrong unit being given, which is thought to happen 1 in 15,000 times, okay, of transfusion. So these are not so rare. And then we have the common events like TACO or alloimmunization. So one article that came out recently was by Jeff Carson. So he compared, in a serious study, by the way, he compared the risk of HIV and hepatitis C with transfusion to the risk of getting struck and killed by lightning. And so he looked at lightning strikes in all 50 states in the US, and he determined that in the most dangerous state in America for lightning strikes, you had a 1 in 2 million chance of getting struck and killed. So people took away the wrong message, I think, that blood is so safe now that we can just give it to everybody. But they forget about conditions like TRALI and TACO, the number 1 and 2 most common causes of transfusion-related death. So what about cost? So this is the dollars per year that we spend at my institution for blood acquisition cost on the y-axis. And I divided it by red cells, plasma, platelets, and cryoprecipitate. And you can see roughly half our cost goes to red cells, half goes to platelets, and we're spending about $28 million a year for our 5-hospital health system, $20 million a year at the single Johns Hopkins Hospital. So if we can save even 5% of our blood products, that's $1.5 million. 10% is almost $3 million in cost savings. And I got to add 2 caveats here, and that is that this is really the tip of the iceberg cost, because one of the most famous papers to come out of the Englewood group is the true cost of blood, which is about 3.5 times the acquisition cost. So this is just the tip of the iceberg. If you look at the cost of bringing a unit of blood all the way from the donor to the recipient, it's about 3.5 times more than this. And the other caveat is that we are virtually either not paid at all or poorly reimbursed for blood by third-party payers, insurance companies, and Medicare. So this really comes right out of the hospital's bottom line. So what about outcome studies? So to look at outcomes, I first point out that we have 4 national societies with guidelines for transfusion triggers of either 7 or 8 grams per deciliter. And now we have 7 randomized trials. These are landmark studies in either the New England Journal or JAMA. Randomized trials all supporting lower hemoglobin triggers than we used to use. And here's the triggers that they support. You can see all of them support a trigger of 7, except the 2 studies in cardiovascular patients, which support a trigger of 8. And then when they compared to higher triggers of 9 or 10, each one of these studies showed either the same outcome, which means no benefit to giving extra blood, or a worse outcome, meaning there was a detrimental effect to giving extra blood. And note that these studies were done in a wide variety of different types of patients. So I want to point out that even super sick patients, like in the ABER study, critically ill ICU patients, 25% of those patients died in the hospital. That's how sick they were. And yet they did no better with a higher hemoglobin. In fact, they did worse with higher hemoglobin triggers than they did with a lower hemoglobin. So why doesn't more blood help? Why wouldn't patients do better? And one of the reasons might be what we call the storage lesion. In other words, what happens to red blood cells when we store them in the blood bank for 6 weeks? And the other way to think of the storage lesion is why your own circulating red cells might function better than a transfused red cell, or why the higher hemoglobin triggers didn't improve outcomes in the randomized trials. So we'll talk about the storage lesion for a minute. And it's well recognized that a transfused red cell from the blood bank, especially acutely following the transfusion, are not normal. So this is what the red cells look like on day 1 when they're fresh. This is what they look like after 3 weeks, and then after 5 weeks of storage in the blood bank. So you can see that they're spiculated, they're misshapen, echinocytes and spherocytes. So these cells are damaged in the blood bank during storage. In fact, biochemically and structurally, there's 5 different changes that are all detrimental. For example, the membrane is less deformable, so it becomes stiffened. And 2,3-DPG is depleted within about a week of storage by about 90%. And other changes are detrimental that could hurt oxygen delivery. So I'm interested in the membrane deformability. That's how flexible the red cell membrane is. And it's important because red cells are about 7 microns in diameter. And you can see they flow through capillary beds that are as small as 5 microns in diameter. And so they have to change their shape to flow through capillary beds. And if the membranes are stiffened, they have trouble changing shape. So we did this study where we looked at the deformability of the red cell membrane shown on the y-axis here. So higher is better and lower is worse, indicating a loss of deformability. And so we took patients undergoing multi-level spine fusion surgery, and we took their blood samples and ran them through an ectocytometer, which squeezes the red cells through a thin channel and looks at the change in their shape. And so those who had minimal transfusion had a small change in deformability, but those who had moderate transfusion, more than 3 units of red cells, had a loss of deformability that lasted for 3 days after their surgery and did not improve. So we think that this damage to the red cell membrane in the blood bank could be permanent and not reversible. So when this article came out, they did a write-up in the newspaper, and they interviewed a few people, including the chief of the Red Cross, and they questioned the shelf life of donor blood, whether we should really be storing it for 6 weeks, because we found that if you got fresher blood, it had better deformability. And he said, the chief of the Red Cross said, the jury's still out. We don't have the answer yet. So the other property of red cells we look at is the hemoglobin oxygen desaturation curve. And so the normal curve is shown here in fresh red blood cells. And then the stored red blood cells have a left shift in the hemoglobin oxygen curve. And so that means they're less able to deliver oxygen after they're stored in the blood bank. However, cell-saver red blood cells that we compared were normal, okay? In fact, they did not have the left shift. So we think that cell-saver red blood cells are higher quality than blood bank or stored red blood cells because they don't have the left shift. And we looked at the reason why they have the left shift, and the reason is 2,3-DPG, shown here on the y-axis. So cell-saver red cells have a normal level of DPG, but blood bank or stored red cells have about a 90% depletion of DPG, which causes this left shift in the curve and less ability to deliver oxygen. So what about the clinical trials on new versus old blood? Should we be using fresher blood is the question, and not storing it for 6 weeks? Well, the first real big study to come out on that is from Colleen Cook, who's now my department chair at Johns Hopkins. She's my new boss. So she had this New England Journal paper in 2008 where she found that if they gave average of 10-day-old red cells compared to 20-day-old red cells, that the patients had a better outcome or less mortality if you gave them fresher blood. And this was a really big retrospective study that triggered 3 randomized trials that followed, one in neonates, one in cardiac surgery, and one in critically ill ICU patients. And guess what? All 3 of the randomized trials were negative. So no difference, no difference, no difference in outcome between fresher blood and older blood. And one of the issues is that the IRBs who make the rules, they didn't allow these randomized trials to give the patients the oldest blood in the bank. Okay, in other words, they use 7 versus 14-day-old blood, 7 versus 28, and 6 versus 22-day-old blood, but you don't see 35-day-old blood or 42-day-old blood because they thought it was unethical to give patients the oldest blood in the bank. Yet we still give it to patients. So this is one of my areas of interest, which is the collection and analysis of data to improve blood utilization. So I was asked to give a talk to the Red Cross about 3 years ago with this topic. And at the end of my talk, this is what we concluded. So we concluded medicine lags behind fast food chains and auto parts stores in automating data collection. And I know that sounds funny, but I think it's actually true. For example, about half of US hospitals still use paper anesthesia records. Okay? And this is what a paper anesthesia record looks like. We gave ours up in 2009. And you can see right here is where you chart blood. It says blood. I think that means red blood cells. I'm not sure. But it's virtually impossible to get data off of paper records. So in 2010, we switched to the electronic record that looks like this. And so every unit of blood and blood component is entered into a database along with the laboratory values like the hemoglobin levels and all the blood we send to the lab. And so now we're able to query the database and to get accurate data to improve practice. So the first thing we did with our electronic records is we decided to rank all of our surgeons on the left at my institution according to their average threshold for transfusion. This is the hemoglobin threshold shown on the x-axis. And then we ranked all the anesthesiologists according to their average hemoglobin threshold for transfusion. And so the left edge of the red bar is the trigger, or the average hemoglobin before the transfusion. And the right edge of the red bar is the average target, or the hemoglobin after the transfusion. So you could see there was a wide variation in practice, about a 3-gram variation among the surgeons and about the same variation among anesthesiologists because we work in the same room together. So this wide variation in practice was recognized as an opportunity for improvement because anytime there's a wide variation in practice, especially with the most common procedure performed in US hospitals, there's a need for improvement because the answer is somewhere in the middle and not on the extremes. So what we did then is we replaced the numbers with names. So we put the names of the surgeons, and we did the same for anesthesiologists. And then people started to pay attention when we put names on the data. So in fact, what else we did is we took the trigger to target range from the 2 biggest randomized trials in the New England Journal. And then we superimposed that shaded range in the middle there. So ideally, all the red bars would line up in the shaded range if we were practicing evidence-based transfusion practice. So there's a lot of overuse going on, as you can see. So then we we put the data on the bathroom door, and then people paid even more attention. So they lined up to see where they stood compared to their peers. This was an anesthesia office bathroom door, by the way. It wasn't truly public. But everybody wanted to know where they stood on the curve on the hemoglobin threshold compared to their peers. And at this point, I tell a story about one of my favorite surgeons with his permission. So he's a surgeon number 44 because he was on the bottom. And he's one of our most famous surgeons who finished his 2000th Whipple procedure recently, which is a difficult operation for pancreatic cancer. And so we think he's done more Whipples than anybody in the world. And so he's highly respected. But I sent him this email with this picture on it on Christmas Day in 2011. And I said, look, you got the highest hemoglobin in the hospital in your transfused patients, like way higher than everybody else. So this is what he told my colleague in his next Whipple. He said, if you hang that blood, Steve Frank is going to be all over our case. So either he didn't like being on the edge of the curve, or he heard about the data on the bathroom door, because he had no idea. I know it's funny, but he had no idea, and we had no idea that his hemoglobin thresholds were way higher than his peers until we looked at it. And then when he saw the results, then his transfusion practice changed dramatically. And so his red cell units per patient has decreased about 60% over the last 3 years. And surprisingly, his plasma and platelet utilization has also decreased. And we didn't even say anything about plasma and platelets to him. But I think a lot of surgeons and anesthesiologists now think if you need some red, you need some yellow to go with it. And if you give less of one, you can give less of the other. So back to patient blood management, some people define it as giving the right dose of the right product to the right patient at the right time. But it's really a little more complex. And I outlined some of the most important methods of PBM, as we call it. Pre-op anemia treatment, I think we're going to hear more about that in a little this afternoon. But I like to say that $5 worth of iron pills beats $500 worth of blood transfused, because then you show up with your own red blood cells instead of requiring someone else's. And sometimes we get aggressive with iron. We give it intravenously, or we even give erythropoietin when we can justify it to treat pre-op anemia. So good surgery and less invasive surgery is important. For example, robotic surgery. At first I thought robotic surgery was a gimmick. Okay, you put it on a billboard and you say, oh, our hospital does robotic surgery, and then the patients come, right? But then I looked at the blood utilization with robotic surgery. For example, the robotic prostates that we do. And we found that 1 in 800 robotic prostatectomy patients was transfused. 1 in 800 patients. And when I did them as a resident, when we did them open, virtually every patient was transfused. And now it's 1 in 800. So robotic hysterectomies are the same way. They're hardly ever transfused. So that makes a difference. Cell saver or blood salvage has been called the centerpiece of blood conservation. It still is for certain types of procedures. Minimizing phlebotomy blood loss. I'm going to show you how much blood per day your patients lose due to lab testing in a minute. CPOE with clinician decision support. That's a lot of words. What it means is the annoying pop-up alerts that warn doctors against giving blood when it might not be indicated. Pop-ups that alert them on the computer screen. Antifibrinolytics, we just heard a lot about that from Dr. Gooby. who's one of the world's experts in this field, and the value of tranexamic acid, especially in reducing blood loss and transfusion. Point-of-care testing like thromboelastograms, if you can get rapid turnaround on tests you send to the lab, you're much less likely to give a transfusion because you're not waiting and wondering for the results. Audits with feedback and education like we're doing today. This is the Cell Saver, and the question is who benefits from Cell Savers? And we think that major orthopedic cases, vascular cases, cardiac cases, and almost any Jehovah's Witness patient or patients who wish to avoid transfusion can benefit from a Cell Saver, unless it's a robotic prostatectomy where the chance of transfusion is virtually zero to start with. In fact, so we had that one paper I showed you already that Cell Saver blood might be better quality than banked blood. This article came out. We recycle a lot of things: paper, plastic, metal, and now blood. We're recycling blood, and we think it's a better quality red cell than the blood bank. So we took a survey in our 5 ICUs to see how much blood our patients were losing to lab tests. And so here's how much blood per day was being removed from the patients just for lab tests. And we included the blood that's sent to the lab, and the blue portion is the blood wasted to clear the lines from the saline inside the lines. And it was about 60 mLs a day in the average ICU, which is just over 1% of your blood volume that's going to the lab every day, which, by the way, is how much erythropoiesis you have every day. You destroy and create about 1% of your red cells every day. So if we send 1% to the lab, you're canceling out any erythropoiesis that's going on. And we found in this one ICU, they used this inline return device where they return the wasted discard back to the patient. And they were able to cut the blood loss in half with that device. And my new chair of anesthesia, my new boss, Colleen Cook, had this paper this year, 2015. She called it Contemporary Bloodletting in Cardiac Surgery. And they looked like we did at the amount of blood patients lose to lab testing every day. And she was, this is an interesting word for a scientific article, we were astonished by the extent of bloodletting with total phlebotomy volumes. This is at the Cleveland Clinic, by the way, equivalent to 1 to 2 red blood cell units that were being removed from the patient. And this was in patients who were in the ICU for about 10 days. That's how much blood they lost. And so we started using smaller phlebotomy tubes. The tubes come in 3 sizes. So we either use the medium size or the smallest size tubes, and we can dramatically decrease blood loss. So this is called Clinician Decision Support. We recently designed this for the Epic electronic health record. And what it is, when you go to order a transfusion now at my institution, if your patient has a hemoglobin of 7 or greater, you get this pop-up alert in yellow, and it says that your patient has a hemoglobin greater than 7, and it basically asks you, are you sure you want to give them a transfusion? And then we even give 2 New England Journal landmark study references in the BPA, the best practice alert. And they can click on those and get a live, full text article to read that justifies the need or not the need for transfusion. So about a year ago, we analyzed our data looking at the education plus the computer provider order entry with clinician decision support. In other words, education plus the pop-up alerts. And we looked at the number of out-of-guideline transfusions with preceding hemoglobin greater than 8 over a 4-year period on the x-axis. And we went from 1,000 units a month to 400 units a month. 1,000 to 400 units a month out of guidelines. So that was a 54% decrease in out-of-guideline transfusions. And the overall change in blood utilization for the 10 different surgical specialties is shown here. And the average was 14% decrease, but you can see there's a variation in change among the surgical specialties. So tranexamic acid, we've already heard about. They're now calling it a game changer in some of the orthopedic meetings. And so we looked at when we started using tranexamic acid in about 2012 for hip and knee replacements. And on the top is the average number of units of red cells per quarter, and the bottom is average number of units of red cells per patient. And so we saw a dramatic decrease in red cell use. Units per patient was down 73%. It wasn't just the tranexamic acid that changed. There were several other changes as well, like the big New England Journal study came out showing that lower triggers were better. And we've hired some new surgeons that came with the tranexamic acid that happened to lose less blood. But that's why it's being called a game changer. It does make a difference. So recently we expanded our blood management program to cover 5 hospitals in the Johns Hopkins Health System. So it started at 1 hospital. Now we're doing blood management at 5 hospitals. And our goal is to promote evidence-based practice. And we have strong support from our health system leadership and the Institute for Safety and Quality. They've now put blood management under safety and quality. And I want to show you just a few screenshots of our dashboards and our reports that we use to improve practice. So this is a very simple dashboard screenshot where we took the 5 hospitals shown here in our health system, and on the bars shows the percentage of red cell transfusions that were for 2 units, that's in red, or orders that were for 1 unit in green. So you could see at 3 of our community hospitals, we had about 2/3 of our transfusions were being ordered for double unit transfusions. Whereas at the other 2 hospitals, a very small percentage of transfusions were being ordered as double units. So we thought this was a big opportunity to reduce blood use. And in fact, the AABB has Choosing Wisely guidelines that suggest giving 1 unit at a time in patients who are not actively bleeding. So when I went to med school, they told me always give 2 units, and now the experts in the field are saying to give 1 unit, or maybe even no units, depending on the hemoglobin threshold. So we started a campaign this year called Why Give 2 When 1 Will Do, and it sounds kind of cute. We didn't make this up. We borrowed it from someone else. And so we had this in our newsletters. We even had it on screensavers around the hospital. Why give 2 when 1 will do? And initially we saw a 31% decrease in double unit transfusions, and now we're up to a 60% decrease in double unit transfusions. This is an example of one of our reports. So we make one of these every month for every department. Okay, so I pick on the Department of Orthopedics here. And we get the data from our electronic health records, and then we show all the orthopedic surgeons at our institution on the y-axis here, and the number of red cells transfused on the x-axis for that time period. So this guy gave the most red cells, okay, twice as many as everybody else. Of course, he's probably doing bigger cases. That's what they'll tell you, at least. And then there's the green, yellow, red. And the green, yellow, red represents the preceding hemoglobin before the transfusion. So green means a hemoglobin less than 7, yellow 7 to 8, and red is above 8. So we think that red definitely represents opportunity to reduce blood use, and yellow is also opportunity to reduce blood use. For example, this guy had no red at all, and this orthopedic person had 80% of the transfusions in the red zone. So it sets up a competition between providers to improve practice. We now have, as of yesterday, I just got this screenshot, we have an interactive dashboard for the entire health system where we can toggle back and forth between hospitals and between services like orthopedics or cardiac or vascular surgery. And we can look at things like, this is the 1 versus 2 unit transfusions, and you can see we have a dramatic decrease in double unit transfusions. And then here's the hemoglobin triggers, and this is month to month to month on the x-axis. We have a decrease in the out of guideline triggers as well, and we can then look at different hospitals and different services or different doctors with this dashboard. So overall, in the last year, this is the change in blood use among all 5 hospitals. And so change in red cells, plasma, platelets, and cryo. And I must add that at 3 of the hospitals, they're just getting started with blood management, and that's why the change is not as large as you might see in other programs, not yet at least. And this is the total cost savings or cost avoidance for red cell, plasma, platelets, and cryo. So in the first year of a health system-wide program, we saved about $1.2 million in cost by reducing unnecessary transfusions. So last thing I want to show before we finish is outcomes, because that's what really matters, is patient outcomes. Saving money and saving blood is not as important as patient outcomes. And so I want to show outcomes first in our bloodless patients who don't accept transfusion, because they definitely get special treatment. I call it extreme blood management, where we pull out all the stops. And I want to show you how they do. And then I want to show you outcomes for the massively transfused patients, which is a new study that we just finished. So we've had a bloodless program at Johns Hopkins, not nearly as long as Englewood has had theirs, only for about 3.5 years. But this is the front page of our website, and you can see one of our residents sitting next to the cell saver. And so I want to talk about our outcomes in our bloodless patients. So about a year and a half ago, we had this paper, Risk-Adjusted Clinical Outcomes in Patients Enrolled in a Bloodless Program. And so we took our bloodless patients and matched them to similar patients who accepted transfusion, and we compared outcomes. And we found that our bloodless patients did just as well or better than the patients who accepted transfusion. And so here's the outcomes we looked at. We looked at heart attack, no difference. Respiratory and renal complications, no difference. Thrombotic complications like pulmonary embolus, no difference. Infections, that's hospital-acquired infections. There were less infections in the bloodless patients compared to the controls, but the study wasn't large enough for that to be statistically significant. And there was less mortality in the bloodless patients compared to the controls. That's in-hospital death. And that was significant, but this is a small study as a preliminary report, so it wasn't powered to prove that there's a lower mortality. But we also looked at cost, and we looked at hospital charges and total cost and direct cost to the patient. And we found about a 12 to 14% decrease in cost for the bloodless patients compared to controls. So we think they do just as well or better with less cost, and we think it's the best care that we can deliver. Last thing I want to show is outcomes after massive transfusion. So we often wondered when we give cooler after cooler after cooler of blood to our trauma patients and our transplant patients, how they do, but we never looked at it. We never knew how they do. So we took every single patient admitted to Johns Hopkins, every patient, and put them on the x-axis according to their dose of blood from 0 to 75 or more units of blood. And then we looked at percent mortality on the y-axis. And so we knew that giving more blood would be associated with a worse outcome, but we didn't know the slope of this curve or the shape of the curve. So what we found is that for every 10 units of red cells that was given, there was a 10% increase in mortality. And at 50 units of red cells, you hit 50% mortality, which had never been reported before. So we coined the term the 50-50 rule. It's like flipping a coin when you get to 50 units if your patient's going to make it. But maybe even more important is we were able with our database to look at different kinds of morbidity. So we took 5 different morbid outcomes shown here in color and plotted them against the dose of blood on the x-axis. And we found that infections and thrombotic events were 4 to 5 times more common than renal or respiratory or ischemic events. And so this had not been reported before either. And so we think that clinicians should be more vigilant to prevent, to diagnose, and to treat infections and thrombosis after massive transfusion in order to improve outcomes. And this is coming out next month in anesthesiology. And I just want to thank all the people that I work with from several different departments at my institution, and including the surgeons, without whom none of this would be possible, and 3 medical students who've taken a year off to do research to work with our group, and a lot of people from anesthesia and patient safety and quality, and then all the people in our bloodless team who I can't say enough about. Thank you much, and I'll take questions.